Hello everyone, and welcome to today's live broadcast, Recent Progress in Predictive Biomarker Testing in Non-Small Cell Lung Cancer, presented by Dr. John W. Longshore, PhD, FACMG. We are excited to bring you this educational web seminar presented by LabRoots and sponsored by Roche Diagnostics. As a global leader in healthcare, Roche Diagnostics offers a broad portfolio of tools that help healthcare providers in the early detection, prevention, diagnosis, and treatment of diseases. In molecular diagnostics, Roche Diagnostics is driven by a vision of working with laboratories like yours to improve the medical value you offer in virology, women's health, microbiology, genomics, and oncology. The company continues to meet unmet needs through its investment in research, innovation, and scientific excellence with the goal of supporting your important role in improving patients' lives. To learn more, visit usdiagnostics.roche.com. I'm Karen Benzing, Genomics and Oncology Marketing Manager for Roche Diagnostics. I'll be your moderator for today's event. Before we begin, I would like everyone to be aware that this event is interactive. We encourage you to participate by submitting as many questions as you like at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. This is an educational webinar and thus offers CE credits. After the webinar has concluded, please click on the CE button located in the bottom left-hand corner of your web page and follow the process to obtain your credits. Also, please note that you will be viewing the presentation in the slide window. To enlarge the window, click on the screen icon located in the lower right. Finally, if you have trouble seeing or hearing the presentation, please click on the support button located at the top right of the presentation window, or use the Q&A button to let us know that you're having a problem. Thank you for your attention. And now I'd like to introduce today's speaker, Dr. John W. Longshore. After completing his undergraduate work in applied biology at Georgia Tech, John received his PhD in medical genetics from the University of Alabama at Birmingham and completed a fellowship in clinical molecular genetics at the Greenwood Genetics Center. Since 2001, he has worked with the Carolinas Pathology Group as Director of Molecular Pathology for the Carolinas Laboratory Network. His primary responsibility is supervision of the Molecular Pathology Laboratory, which provides state-of-the-art molecular testing services for the hospitals and facilities within the Carolinas healthcare system. Dr. Longshore is a diplomat of the American Board of Medical Genetics in Clinical Molecular Genetics and an active member of the American College of Medical Genetics, the American Society of Human Genetics, and the Association for Molecular Pathology. Away from his professional life, John enjoys fly fishing, swimming, travel, and spending time with his wife and children. Please join me in welcoming Dr. Longshore. I will now turn the presentation over to him.
Good morning. Thank you very much, Karen, for that kind introduction. Thank you to LabRoots for the invitation to present in this session today and to Roche Diagnostics for their support of this program. Biomarker-based therapy in oncology has become the standard of care over the last decade, and it's certainly an exciting time in the field of personalized medicine and companion diagnostics. Although I work for Carolinas Pathology Group, my primary professional responsibility is directing the molecular pathology lab for the Carolinas healthcare system, which is a large integrated health network based in Charlotte, North Carolina. It's a 43-hospital system that has large academic tertiary care centers as well as small community hospitals and about 62,000 employees at 900 care locations. Therefore, we have an extremely diverse set of physician needs for biomarker testing, both in the community setting and the academic type setting. But the primary enterprise for Carolina's healthcare system is in Metro Charlotte, North Carolina. My lab is a full-service molecular pathology lab providing assays in all molecular specialties. We also have a very robust clinical trial central pathology operation and extensive experience with multiple companion diagnostic or personalized medicine platforms. We offer all available companion diagnostic targets in my laboratories, both with DNA, FISH or fluorescent in situ hybridization, and immunohistochemistry-based testing. In addition to that, we have next-generation sequencing available for expanded screening when that is indicated for patient care. So let's move on to talking about lung cancer, because it really is a significant global health issue. We spend a lot of time in the United States in October talking about breast cancer and women's health, where we think of all the pink that we see, and in November, prostate cancer or men's health. But in addition to those two very worthy causes, lung cancer is a far more common cause of death in the United States. We see about 1.8 million new cases per year. So within the Carolinas healthcare system and the Levine Cancer Institute, that means we have over 3,000 new cases of lung cancer that we see on an annual basis. So why is lung cancer so fatal? This really relies upon the fact that lung cancer is usually diagnosed in an advanced stage, which means that over 50% of patients with lung cancer are diagnosed at stage 4 or advanced metastatic cancer. We have a limited but a growing number of targeted therapeutics, but overall still a fairly poor 5-year survival rate, even with these dramatic advances in therapy that have been made over the past few years. So let's begin our presentation today talking about a few core concepts that I think will aid us as we get into the presentation. What is a biomarker? In its most basic form, a biomarker is a biological event that is associated with an abnormal cellular behavior. This can be a genetic alteration that can be detected with a molecular or DNA-based test, or it can be a protein expression or chromosomal translocation that can be detected with immunohistochemistry or FISH or fluorescent in situ hybridization. Now moving forward into companion diagnostics. A companion diagnostic really has a dual purpose. It is first and foremost the detection of a biomarker, and then secondly, utilization of the biomarker information in patient care, either in selecting patient therapeutics, determining the duration and dosage of therapeutics, and also helping to reduce adverse outcomes. The FDA did a very nice job of summarizing what a companion diagnostic is, that you can see at the bottom of the slide. An IVD companion diagnostic device is an in vitro diagnostic device that provides information that is essential for the safe and effective use of a corresponding therapeutic product. We have something new that is called a complementary diagnostic that has been approved by the FDA within the past few months. A companion diagnostic is relatively easy to understand, a complementary diagnostic much less so. A complementary diagnostic is a test that provides additional information about how a drug might be used, whether someone might respond to a class of drugs, but is not required for the safe and effective use of the drug. And at present, we only have one complementary diagnostic that is approved in the U.S. market, and this is nivolumab or Opdivo from Bristol Myers Squibb. It is associated with the DACO 288 PharmDx immunohistochemistry test. And so there is no label for the testing within the drug prescribing information. So this really leads us to BC with complementary diagnostics. Will testing be ordered? And only time will tell if it is truly a competitive advantage for a therapeutic to have a label as a complementary diagnostic versus a companion diagnostic. So we do have lots of challenges with implementing companion diagnostic testing in the U.S., so I think it's important to remember these. We have difficulty conserving sufficient tissue in pathology, collecting sufficient tissue during the biopsy process. We have multiple methods that can be used for personalized medicine testing, with each having a different sensitivity and specificity. And this kind of flies in the face of the gold standard of companion diagnostics, which is standardization of the testing process. We struggle with reimbursement for newer biomarker tests. Patients see usually a wide delay between their presentation with clinical symptoms and the results of their biomarker testing being returned to them. We have limited clinical information for non-driver mutations, which is really a challenge with next-generation sequencing panels. We have still many institutions that do not have or heavily utilize multidisciplinary tumor boards, particularly systems that are geographically isolated clinics and specialties. So I have some solutions that may be helpful with that. And then it's also very important and challenging to stay current in a rapidly evolving oncology setting. Challenging to maintain up-to-date laboratory report information, stay current with clinical testing guidelines, and also stay current with available clinical trial enrollment opportunities for oncology patients. So let's talk a little bit about the lung cancer patient journey. It is quite complex and involves many, many steps. I have counted as many as a total of 20 processes or steps that a patient would be involved with. In diagnosis, they will have their clinical presentation, then imaging and radiology, a biopsy that's performed, testing that's performed, and then results communicated back to them. As far as the physician specialties that would be involved, they would likely present with their initial symptoms to primary care, then be referred to a radiologist for imaging, then to an oncologist, then either to a radiologist or a pulmonologist for a biopsy collection, and then to laboratory medicine or pathology, both for diagnosis, histological diagnosis, and any needed biomarker testing. So a question today is, how do we help to expedite this process given its many cumbersome steps and multiple medical specialties that are involved in patient care? So how important are companion diagnostics in oncology today? For reference, let's review the NCCN non-small cell lung cancer guidelines, and these are the most up-to-date guidelines. As you can see, after a histological diagnosis is established, companion diagnostic tests alone drive treatment decisions. And for non-small cell lung cancer, these tests are EGFR and ALK at this time. In addition, the NCCN recommends expanded screening for non-small cell lung cancer to determine eligibility for future therapeutics, such as in BRAF, MET, ROS1, which is now approved for crizotinib therapy, HER2, and RET. So this is why we are here this morning. If we look at the biomarker testing journey, how do we go from a symptomatic patient to the best treatment decision as rapidly as possible? Because time is precious, and we want to get as many patients as possible enrolled in targeted therapeutics or clinical trial opportunities that they have. But as we mentioned earlier, there are many, many steps and many specialties involved in this process. This is a current list of approved companion diagnostics in oncology. The oldest test that you will see on here, or the grandfather of companion diagnostics, would be for HER2/neu and trastuzumab, which has been on the market for almost a decade. The newest approvals in the companion diagnostic world would be for EGFR and Tagrisso, or osimertinib, that was approved in November of 2015, and also for the PD-L1 inhibitor pembrolizumab, or Keytruda, that was approved in late 2015 as well. All of these tests have three associated techniques. Immunohistochemistry is used for companion diagnostic testing in HER2, ALK, and PD-L1. FISH, or fluorescent in situ hybridization, is used for HER2 and ALK, and PCR-based testing, usually real-time PCR, is used for the balance of tests for companion diagnostics in oncology. So let's move into EGFR, because today we're going to spend quite a bit of time discussing EGFR, ALK, and PD-L1 in greater detail. With EGFR, or the epidermal growth factor receptor, there are at this present time in the U.S. 4 approved therapeutic agents on the market and 2 approved companion diagnostic tests, the Roche-Cobas EGFR test and the QIAGEN TheraScreen test. Therapy is indicated for patients with exon 19 deletions or exon 21 substitution mutations as detected by an FDA-approved test. Osimertinib is directed at T790M positive patients that can be detected with the Roche EGFR version 2 test. Within the EGFR gene, there are a wide variety of mutations that are illustrated in this graphic. Exon 19 deletions and exon 21 substitutions comprise approximately 90% of all mutations that you see in patients that are positive for an EGFR mutation, and these patients would be eligible for biomarker-driven therapy. Within exon 20, the T790M mutation is the primary resistance mutation that you see in these patients. There are others, such as mutations in exon 18, that show increased sensitivity to tyrosine kinase inhibitors, but at present have no drug label claim. One of the real challenges that we have working with lung cancer is it's the smallest biopsies, usually a core needle biopsy or a fine needle aspirate, and the largest number of tests that we have to perform. So it can be very challenging to have sufficient clinical material available to perform all needed diagnostic testing. After treatment with targeted therapy or the primary EGFR drugs, resistance begins to develop for patients with exon 19 deletions and L858R mutations. We now know that approximately 2/3 of these patients develop resistance through the T790M mutation. And right now we have one approved therapeutic from AstraZeneca on the market in the U.S. that targets the T790M mutation within EGFR. After a durable response, however, many of these patients go on to develop tertiary resistance due to either MET amplification or histological squamous cell conversion or other processes. So it seems that this is a never-ending process to chase resistant mechanisms for the EGFR mutations. Something you hear quite a bit about today is the sensitivity for the T790M mutation. It's typically a much more challenging mutation to detect than an exon 19 deletion or an exon 21 substitution mutation. And at present, only one test in the U.S., the Roche-Cobas test, has a claim to detect the EGFR T790M mutation. The mutation sensitivity varies quite widely between currently available tests that can be performed to detect this mutation, ranging anywhere from 2.2 to 5% to up to 17.5% for tests available on the market, where it is in the level of 2 to 3% for other EGFR mutations. Based upon work that's been performed in my lab and others, we also know that the sensitivity of the T790M mutation is much more challenging to detect with next-generation sequencing than it is with a real-time PCR assay. So my advice would be to choose your testing platform wisely and quite carefully for the best sensitivity for the T790M mutation. It's also interesting that many responders to therapy in T790M negative patients that you will read about in clinical trials are likely due to test sensitivity issues. So please choose your testing platform wisely for T790M mutations. Moving into ALK, the anaplastic lymphoma receptor kinase, or the ALK mutation. There's a translocation commonly associated between ALK and the EML4, which is the dominant fusion partner, but there are several others such as KLC1, KIF5B, and TFG that are translocation partners of ALK. This drug, crizotinib, that is associated for ALK-positive patients has been approved in the U.S. market since August of 2011, and we see ALK mutations in somewhere between 3 to 5% of non-small cell lung cancer patients. Initially at approval, the Abbott Vice's ALK break-apart FISH probe was the associated companion diagnostic test, but in 2015, the Ventana D5F3 immunohistochemistry test was retrospectively validated as a companion diagnostic. So therapy is indicated for ALK-positive non-small cell lung cancer patients as detected by one of these two FDA-approved methods. We also have two quasi-companion diagnostics, I will call, ceritinib and alectinib, that are available in the market for patients who are either intolerant to crizotinib or who have progressed on crizotinib therapy. So although they do not have an associated companion diagnostic test, they are only indicated for patients who have progressed on crizotinib therapy. So therefore, these patients will have had companion diagnostic testing prior to using one of these two therapeutic agents. So I mentioned on my last slide, ALK also had a second companion diagnostic that is immunohistochemistry based, approved in June 2015. The Ventana D5F3 assay was cleared for use with crizotinib as a companion diagnostic, and it shows some advantages over FISH that it has a binary scoring algorithm looking for granular cytoplasmic staining of tumor cells. With the fluorescent in situ hybridization or FISH-based test, we look for greater than 15% of cells showing the translocation to be considered positive for the FISH result. However, with immunohistochemistry, any % positive tumor cells are considered a positive result, and patients would be eligible for crizotinib. So there are some competitive advantages for IHC versus FISH for looking for the ALK translocation. It's more rapid, less expensive, much more widely available in histology labs, and requires many fewer tumor cells for analysis, as I will show you on the next slide. And also there are some ongoing studies that show crizotinib response in some patients who are negative for the FISH ALK test but positive for the IHC test. Availability of this IHC testing should expand access to the therapeutic. Now, if we look at these advantages and disadvantages of ALK versus FISH, I think you can see that the immunohistochemistry assay can be much more easily automated. It uses conventional microscopy versus fluorescent microscopy. It has a quicker turnaround time, a binary scoring algorithm, is less expensive and is available in many more histology labs versus cytogenetics or anatomic pathology labs for the FISH testing. It also seems to have a higher catch rate for crizotinib therapy. So it will be interesting to see the traction the IHC test gains in the market over the next year. This case is a really nice example of the power of immunohistochemistry in looking at small tumor samples. As I said, we use binary scoring for immunohistochemistry, so any cluster of staining cells is considered a positive result. If you contrast this with FISH, you need at least 50 cells to be evaluated to be able to have statistical significance to find a positive result for ALK testing. So the availability of IHC testing, such as for the patient illustrated in this slide or the tissue illustrated in this slide, gives the patient access to a therapeutic who would otherwise not be eligible to receive targeted therapy. One of the joys of oncology testing is working with formalin-fixed paraffin-embedded tissues. They have a variable tumor content. We have tumor heterogeneity within these tissues and a variable mutation spectrum. They are mixtures of normal and tumor tissue, and within the tumor tissue, some cells will contain the mutations you are looking for, others will not. Formalin damage yields a small amount of amplifiable DNA due to breaking the DNA backbone, and we also have to deal with necrosis, melanin, and sometimes decalcified tissues when we work with formalin-fixed paraffin-embedded tissues. So proper sample prep is essential for getting a high-quality biomarker testing result. After tissue collection, we fix the sample, we cut unstained slides, and we perform an H&E stain to determine the tumor content, which yields a blue or purple color to the tumor and the nuclear features of the cells. Usually for our biomarker testing for EGFR, ALK, and ROS, we will use 4 unstained slides and obtain 1 H&E stain slide that we use to determine tumor content, and these are cut at a 5-micron thickness. This is a great example of a tissue that came in recently that has quite a large amount of tissue. You can see 2 large tissue cores and 1 small core in the middle, but the problem is there is only 2% tumor content. So we hear a lot of talk these days about making sure we have sufficient tissue available for biomarker testing, and really what we need to be talking about is making sure we have sufficient tumor content available for all needed biomarker testing. But however, in this case, with the testing methodologies that are used in my lab, we were able to detect an exon 19 deletion and an EGFR T790M mutation off of a single slide, even with this low amount of tumor content in this sample. As a second example, here are 3 samples that arrived recently in my lab in a single day, just a wide variety of samples that come in. The first one in the upper left hand of your screen, you can see has about 70% tumor content. It's a very small tissue of a primary lung cancer, but has a high degree of tumor content. Below it is a sample that also has a very small amount of tissue of primary lung cancer and approximately 3% tumor. Just 1 small island of tumor is available in this sample. Contrast this with the sample on the right, which is a large lymph node that has massive amounts of tissue and tumor available for testing, and this is from a metastatic lung cancer sample. So you really never know what type of samples are going to come into your lab on a daily basis for biomarker testing in the lung cancer world. It is truly a wide variety of samples and sample types that you do see. Tumor heterogeneity is a large problem in any biomarker testing environment. As I mentioned on an earlier slide, you have mixtures of normal cells and tumor cells, and then within the tumor cells you have cells that are positive for mutations you were looking for and cells that do not have the mutation you were looking for. And also, as we cut through the tissues in a FFPE block with 5-micron slices, the mutations vary as we section the biopsy on a microtome. And one exciting development that we have that's widely used in the European Union and is used on an experimental basis in the United States is plasma-based testing, which may help address the issue of tumor heterogeneity and tissue heterogeneity for lung cancer. I prefer and find it very easy to think of tumor heterogeneity using the Dalmatian as a model. If you think of a Dalmatian as a tumor, so this will be our animal model, so to speak, they are born with a white coat, so we'll say white coat would be, white cells would be all normal cells. Spots begin to develop in Dalmatians when they're 3 to 4 weeks old. They become more numerous throughout life, and every dog is different, just like every tumor is different. So if we were using the coat of a Dalmatian as an example of a lung tumor, with the dark cells or dark spots on a Dalmatian being the areas of the tumor that had mutation and white spots being those that do not, when you perform a biopsy, it's very difficult to know exactly what you're getting. We can't perform a biopsy knowing that we are going to hit tumor every time. So multiple navigational approaches and navigational bronchoscopy are wonderful techniques that help us work around some of these problems with tumor heterogeneity, since we can use multiple navigational approaches during the biopsy process. So why would you want to use a companion diagnostic instead of another lab technique for a given target? If we consider something as simple as BRAF, the V600E mutation, that is a point mutation, we could use something as simplistic as a PCR restriction enzyme digest that has been around and described since its use in sickle cell anemia in 1978, which was the first widely used molecular diagnostic test. But if you do a rough count, there are at least 11 possible diagnostic techniques that can be used for mutation detection of a point mutation. The most common method that's used in the U.S. and around the world, according to our proficiency surveys, is Sanger sequencing, which is also associated with the worst outcomes because of the poor sensitivity in oncology samples. Sanger sequencing has been illustrated in multiple studies in the peer-reviewed literature to have in the neighborhood of 30 to 50% sensitivity for oncology specimens. And also, when we talk about DNA sequencing, we really don't know what people are referring to anymore. Are we talking about traditional radioisotope Sanger sequencing that is still used in many areas of the world, fluorescent capillary sequencing with enrichment for Sanger sequencing, or are we talking about next generation sequencing? Because sequencing is the most commonly used mutation detection technique worldwide, and unmodified Sanger sequencing has very poor performance for oncology testing, but it's wonderful for blood-based genetic testing. And this largely is due to tumor heterogeneity and the problems with working with formalin-fixed paraffin-embedded tissues. So it can be quite powerful with next-generation sequencing or have many pitfalls with traditional unmodified Sanger sequencing. Europe has a strong history of excellence in molecular diagnostics. And while I'm showing the data on the next two slides, this is not unique to Europe. Our College of American Pathologists data in the U.S. shows exactly the same problems that we have. But in a recent KRAS external EQA assessment in the EU with 59 labs participating, they found a 30% error rate or were unable to generate the correct result using FFPE slides as the sample type. They were both false positive results, false negative results, incorrect mutations reported, DNA isolation failures, and overall test failures. So a wide variety of problems, even in highly sophisticated laboratories. This is why we need standardization. This prior slide I was considering dropping from my presentation since it was several years old, but at the European Cancer Congress meeting in Vienna last September, I was privileged to hear a presentation looking at the EQA quality schemes for KRAS and for EGFR over the last few years, and the EQA schemes are much more rigorous than our CAP surveys that we have in the U.S. And there's continued difficulty reporting correct answers for these. Both from 2009 to 2014 with KRAS, you can see about 70% of labs reported the correct genotype. For EGFR in 2014, only 61% of the labs reported a correct genotype. So even within highly sophisticated molecular pathology labs for personalized medicine, due to tissue heterogeneity and different methodologies that are used, there is a very high error rate. And this is why companion diagnostics are beautiful, because they help standardize testing processes and eliminate the possibilities of error for biomarker-based testing. As I said on my last slide, even within a highly skilled molecular diagnostic lab, opportunities for variations abound. With methods, there are at least 11 methods that can be used for biomarker testing. For pre-analytical errors, what's the sample type? How is it fixed? Where is the section in the FFPE block? What is the tumor content? And what is the mutation content? For DNA or RNA isolation, was it manual or automated? How did you deparaffinize your samples? Did you use a kit? Did you use phenol chloroform isolation? Was it column-based? And did you start with scrolls or glass-mounted slides? For instrumentation for PCR, did you use an ABI instrument or rotor gene? a Z480, a light cycler 480 2.0? Did you do sequencing, next generation sequencing, or a PCR digest? And then within even the professional interpretation, who actually does that? Was it a technologist or was it automated? What was the experience level of the person performing the interpretation? Was it the lab director, and were they appropriately certified for performing this testing? So there are many opportunities for variations even within highly sophisticated labs, and that's why standardized testing processes really are helpful in personalized medicine. Let's talk about the importance of test result accuracy and how this can impact patient care in personalized medicine. If you have an invalid result, a patient will have delayed treatment, disease progression, and an additional biopsy may be required. If you have a false negative result, a patient is not considered for targeted therapy. If you have a false positive result, a patient is considered for a targeted therapeutic that may not be beneficial and in some cases can be harmful. So only with the correct biomarker detection is a patient considered for targeted therapy associated with the improved clinical outcomes and quality of life outcomes we see with targeted therapy. So within laboratory and molecular laboratories in particular, test accuracy is always important, but it has an extremely increased emphasis in companion diagnostic or biomarker-based testing. If ever there has been a win-win scenario in medicine, companion diagnostic testing is the champion. Patients get the best treatment, physicians and providers are able to optimize therapy and minimize adverse events, payers and reimbursements see longer life, reduced resource utilization, and policy and regulatory makers avoid unnecessary care. Even third-party payers love companion diagnostics, since a test costing a few $100s can help predict efficacy for a $10,000 to $12,000 a month targeted therapy. Never has tissue conservation been more important than today with lung cancer. We have the smallest biopsy and many, many tests that are required. Strategic specimen conservation does require multidisciplinary planning. Make sure you obtain sufficient tissue in the biopsy process, and this would be 4 to 5 FNA passes, 4 to 5 transbronchial biopsies, or 2 to 3 CT-guided core needle biopsies. Try to limit your IHC markers used for histological diagnosis to those that are absolutely necessary, and choose optimal companion diagnostic and biomarker test. Prioritize your samples that contain the highest tumor content for molecular testing, sequence your test appropriately, or triage your testing appropriately, and choose your platform wisely. Most of the biopsy procedures in my large hospitals are performed with navigational bronchoscopy, or EBUS, which gives us the ability to perform biopsies with core needle biopsies, fine needle aspirates, or even a forceps biopsy. We have standardized the process down to 4 passes, looking at multiple sites in a single procedure, giving us a very high safety profile, and always gives us sufficient tissue for molecular testing. So the appropriate type of biopsy and biomarker tissue collection is really what drives the personalized medicine conversation around the world. This is a great example of how we use electromagnetic navigational bronchoscopy in the biopsy process. This is a 54-year-old patient who had clinical progression on erlotinib therapy, had one biopsy that was a CT-guided biopsy that was non-diagnostic. A second CT-guided biopsy had quantity non-sufficient for molecular testing, and the patient had a pneumothorax that required placement of a chest tube. And we used navigational bronchoscopy with EBUS for the third biopsy, and you can see with the pink arrow in the diagram, we were able to biopsy a level 7 lymph node, a 6 millimeter diameter lesion. And so it is a wonderful technique for our pulmonologists to get to use that. And looking at this, you can see the catheter tip in the images, and the green dot is the target lesion that they are approaching with navigational bronchoscopy. One of the nice things of multidisciplinary tumor boards is the tissue awareness, because we have traditionally used excessive IHC stains in tissue testing to obtain histological diagnosis. And so these multidisciplinary tumor boards that most of us participate in help drive the tissue stewardship conversation. Within our system, when clinical and radiologic features favor primary lung cancer, we limit ourselves to 2 IHC stains in non-small cell lung cancer. And this would assume that there's no history of prior non-lung malignancy and no strong evidence of squamous or glandular differentiation. We use TTF1 as an adenocarcinoma marker, and we use P63, or in most cases P40, as a marker for squamous cell carcinoma. So our process is really attempting to limit unnecessary stains to leave sufficient tissue available for all needed biomarker testing for patient care. I'll say just one slide about multidisciplinary tumor boards because I think both in the academic and the community setting, they should be the #1 objective that we are trying to achieve, because many studies have shown how they increase patient care and have a wide impact, both by allowing physician and provider communication and using efficiently system resources and personnel. One issue we have is that it's very challenging to find a meeting time that works well for all specialties. In our system, we have found that either 7 a.m. or noon conferences work very well, and since we are a geographically diverse system, we have live, web-based, and call-in options due to a significant infrastructure investment our system has made. Everyone that participates knows that this takes quite a large amount of time to prepare these cases, but it's a wonderful collegial environment, and the benefits really do outweigh the increased time commitment to prepare materials for multidisciplinary tumor boards. So if you do not participate in MDT boards, I highly encourage you to help set them up in your institution. Now we've talked a little bit about tumor heterogeneity, so let's talk about oncogene and mutational heterogeneity that you see for driver mutations. Within lung cancer, we've talked about ALK, EGFR, and ROS1, but we also have RET, BRAF, RAS, MET, and PIK3CA. So after treatment, in addition to the oncogene and mutational heterogeneity that we see in non-small cell lung cancer, we can also have heterogeneity in resistance mutations. If we look at the evolution of molecular pathology knowledge for non-small cell lung cancer over the last 25 years, our first biomarker was histology, being able to differentiate an adenocarcinoma from a squamous cell carcinoma. We initially found that patients with non-small cell lung cancer had KRAS mutations and EGFR mutations, and then in 2009 we started talking about drug sensitivity mutations in EGFR, both a primary drug resistance and acquired drug resistance. In today's time, we know that it takes at least profiling of 18 genes to fully characterize a non-small cell lung cancer. So the smallest biopsy with the widest number of biomarkers that we need to assay in today's molecular laboratories. The quest for knowledge has really led us to next generation sequencing. Multi-gene pan-cancer panels are widely used for biomarker screening. They are very useful for initial biomarker screening, but are considered off-label for prescribing companion diagnostic therapeutics. Many of the panels have very limited clinical information for most of the panel targets and mutations, and in the community setting, usually next-generation sequencing is sent out, although it may be performed in-house in academic or large community settings. Many oncologists have data anxiety due to the large number of mutations and a large amount of information, bioinformation they get back from a next-generation sequencing panel. Accurate informatics are required. The therapeutic information in the reports needs to be constantly updated, which can really be challenging for a large next-generation sequencing panel. But really one of the nice things about next-generation sequencing panels is it helps us drive clinical trial enrollment opportunities for rare targets. We still think that single-gene companion diagnostics or small next-generation sequencing panels are much more appropriate for therapy selection. So we use NGS screening on the front end, and then we back it up with a FDA-cleared companion diagnostic for therapeutic selection in most instances in my system. Now let's talk a bit about immunotherapy, or PD-1 or PD-L1, as we mentioned earlier, then the associated companion or complementary diagnostics. One of the newest companion diagnostics is pembrolizumab, which is a PD-L1 inhibitor, is associated with the 22C3 PharmDx DACO immunohistochemistry test, which detects PD-L1 expression. Increased expression of PD-L1 is usually associated with an increased drug response for this immunotherapy. PD-L1 inhibitors enable T-cell targeting of tumor cells and ramp up or increase the immune response. and they are approved in non-small cell lung cancer after progression on platinum doublet chemotherapy or targeted therapy. As I mentioned earlier, pembrolizumab has an associated companion diagnostic test, so both the therapeutic label, which is at the top of the slide, and the test package insert mention each other in their intended uses, and these can be shown or seen on these slides in the red box. So it is very easy to understand the relationship between the drug or therapeutic and the biomarker-based test, since they require each other for effective use. Now contrast this with nivolumab, which is a complementary diagnostic. If you look at the prescribing indications for use for the drug in the top half of the slide, you will see no mention of biomarker-based testing that is associated. Only in the intended use for the immunohistochemistry test at the bottom, which you can see in the red box, do you see that the test mentions that it can be used to select patients for nivolumab therapy. So this leads to several questions, because are the 28.8 and 22C3 IHC tests that are companion diagnostic and complementary diagnostic interchangeable, or do you need to use a specific immunohistochemistry test for each therapeutic? And if you have a complementary diagnostic test that is not required for safe and effective use of a therapeutic compound, will the testing be ordered? Now, this is what is occurring in the lung cancer space, but we know that both PD-L1 inhibitors require no testing at all for melanoma. There really is much buzz today regarding immunotherapy for PD-1 and PD-L1 in many cancer types. What we do know about PD-L1 expression, it is dynamic and heterogeneous. It's unclear what level of expression is clinically significant, and we know that there are multiple therapeutic compounds available in the market. Also, there are many IHC antibodies that have variable scoring criteria, variable instrumentation that is required. We don't know what the sample source is, and if the testing has to be performed off a fresh tissue, or a biopsy or progression performed at patient progression, or if archival tissue that were used for patient diagnosis can be used. Also, the ability of PD-L1 to act as a biomarker appears to differ dramatically between different tumor types, and it can be particularly problematic for the community setting where not all IHC antibodies may be available, and you may have to select antibodies that are only performed on your immunohistochemistry systems that you have available. So what does the future hold for molecular testing? We have single gene tests, we have next generation sequencing, we have tissue-based testing, and we have plasma-based testing that is emerging. It's widely used in the European Union and is an emerging technique in the United States. I think for initial patient profiling, we will still be performing that with tissue, likely a large next generation sequencing panel, and then we will follow that up with tissue or plasma-based testing, single gene testing for real-time PCR to monitor a patient for therapeutic use, and also use real-time PCR for tissue, or probably in the not too distant future with plasma, to monitor the therapeutic response, and then when patients progress, maybe perform an additional larger panel and go back and monitor patients with single gene test with tissue or plasma. So I don't see next generation sequencing really replacing single gene biomarker testing. I think they are complementary techniques, and for many, many years we will be using single gene biomarker tests due to their sensitivity and specificity, along with next generation sequencing panels to stratify patients for therapeutics, both using tissue and plasma-based testing. Now, we do have a long journey ahead. Just to give you an example of the challenges that we talk about with sophisticated biomarker testing, I gave a lung cancer education event in my home state, North Carolina, early last year, and there was actually a cigarette vending machine in the back of the room where I was giving the lung cancer education story. So we have many lifestyle and environmental choices that patients need to make to help us reduce the risk and rate of lung cancer as well, because we really do not see the huge benefit of these wonderful targeted therapeutics if people are not making appropriate lifestyle choices. So no matter how sophisticated we are in medicine and molecular diagnostics, we still need patients to make healthy choices as well. So to summarize where we are with the presentation, I think while there are many challenges to implement biomarker testing, it is the standard of care for non-small cell lung cancer, both in the academic and community settings. Please remember that biomarker testing methodology selection is critical. choosing companion diagnostic tests and their improved performance versus laboratory developed tests, the techniques that are widely used with real-time PCR, immunohistochemistry, FISH, and next-generation sequencing. And then also something that is very important that I cannot emphasize enough is the importance of multidisciplinary tumor boards in helping provider communication between the many specialties that are involved in caring for and diagnosing lung cancer patients. It's also, I think, the big take-home message is that targeted therapy in the era that we are, both for lung cancer, for colorectal cancer, for melanoma, and many other tumor types, is wonderful. Targeted therapy really is improving the patient experience and improving patient outcomes. And I thank you very much for your attention. And at this time, I think we'll move into our question and answer session.
Thank you, Dr. Longshore, for that informative presentation. Now it's time for question and answer. If you have a question you'd like to ask Dr. Longshore, please do so now. Just click on the green Q&A button at the lower left of the presentation window. Type your question into the box that appears on your screen and click on the send button. We'll answer as many of your questions as we have time for. So with that, let's get started. Our first question, Dr. Longshore, do you feel that physicians are proficient in selecting the correct test panels, and how are they educated in the fast-changing field?
Oh, that's a great question, because you definitely in the oncology setting see two types of oncologists. You see those who are very particular about making sure that their patients are tested with a particular type of test, and you see other oncologists who rely upon pathology in the molecular lab to choose the best platforms and best methodologies to be used for their testing. I do think that it's something that requires some education, and we do a lot of that at our multidisciplinary tumor boards as well, because as a molecular pathology specialist or a pathologist, we certainly have a day-to-day grasp of the testing environment and testing landscape. So I think that's a decision that really needs to be made based upon the type of materials you have available from your biopsy collection, with pathology and oncology working hand in hand, because there are some very powerful tests that have some drawbacks as well, and making informed testing decisions are very important.
Okay, our next question. We know that heterogeneity of tumor tissue itself is a problem. Do you have any suggestions for how you can maximize the testing process so that you can get a better representation of the mutations that are reflective of the whole tumor?
Yeah, that's another great question. Tumor heterogeneity is something that we all deal with. One thing that we try to do on the tissue side with navigational bronchoscopy is to do multiple navigational approaches during the biopsy process. So if we approach a tumor from multiple angles or multiple navigational approaches, we're actually biopsying different areas of the tumor, which can help cut down on tumor heterogeneity, because then those cores are going to be placed into the same plane when we put them on the microtome to use them for biomarker-based testing. The other exciting future use may be for the so-called liquid biopsy or plasma-based testing, because for patients whose tumors shed DNA, we do know that they don't just shed from one area, but shed from the entire tumor. And liquid biopsies, although at present have slightly decreased sensitivity versus tissue-based testing, seem to do a much better job of managing tissue heterogeneity and give us a much broader picture of what's going on in the overall tumor versus the single 4 or 5 micron section that we may have selected for tissue-based testing.
Great. Our next question, do you feel that the tissue requirement for the companion diagnostics, the fact that they do actually require biopsy tissue, do you feel like that is providing any harm to the patients? Is it limiting their treatment availability? Just thoughts on getting tissue.
Right. I think, getting tissue seems to be, in my experience, getting sufficient tissue is less of a problem now than it was 5 years ago, when kind of the golden age of companion diagnostics started. I think most of the modern companion diagnostics have a very minimal tissue input. It may be slightly greater than what the claims are for some of the next generation sequencing panels, but what my lab and others have found is we are getting clonal selection and not a very good representation of the tumor when we use the minimum amount of tissue for a next generation sequencing panel. So we found that the sensitivity offered by on-label companion diagnostic testing is better than what we can get with a next generation sequencing panel. For EGFR, really is all I can speak for, because that's all we have looked at. But certainly is an issue. It's not a big problem getting sufficient DNA from a small biopsy if you use an appropriate isolation method to perform companion diagnostic testing. So from a normal fine needle aspirate or a core needle biopsy, we always have sufficient material to be able to perform EGFR, ALK, ROS, and any other downstream tests we need, in addition to an NGS panel if it is indicated. Great question, though.
Another question about what happens to the mutations in these lung cancer patients when they're on treatment and then following treatment? What do we see as a pattern for that evolution?
That's a good question. We don't have a lot of information since we don't serially test patients outside of a clinical trial. But normally what we see is due to selective pressure in EGFR with exon 19 deletions and the L858R mutations, is we tend to see them decrease during therapeutic and emergence of resistance mutations. What remains to be seen is when you take a patient off of a targeted therapeutic for a period of time and then re-challenge them with the same targeted therapeutic for an exon 19 deletion or an L858R mutation, they do seem in many cases to respond again. So it's not a single use of a targeted therapeutic. They can often be re-challenged with the same therapeutic after they've developed resistance and perhaps been treated with a targeted therapeutic that is specific for the resistance mutation. So it is a kind of a cat and mouse game that you have to play. One thing that is, I think, particularly exciting that we're starting to see in clinical trials is combination therapy or multiple therapeutics being directed at a particular mutation and its rescue pathway, maybe the most common resistance mutation pathway. And I think targeted therapies are something, combination targeted therapies are something we're going to see a lot more of over the next few years, because it will really give us a improved duration of response if you were targeting both the driver mutation and its primary resistance mechanism at the same time.
Do you think that as technologies evolve, that we will start to look at serial monitoring for these patients as a viable alternative to get ahead of treating them and keeping them healthy?
Right, another great question. I think one of the drawbacks in doing serial monitoring of patients with tissue is that it's an invasive process every time a patient has a navigational bronchoscopy or a CT-guided biopsy performed. That's one of the exciting things about the emerging field of liquid biopsies and plasma-based testing, because we can then start performing serial testing, perhaps even looking at the load of mutation present in a patient's bloodstream if their tumor is shedding DNA, and then probably determine the development of a resistance mutation. We will see that before we can see it in a tissue biopsy. So I think that really is going to be what we are doing. The other thing that's nice about that is while CT-guided biopsies and navigational bronchoscopy usually are performed in your larger community settings or in your academic higher tier medical centers, you don't see a lot of that in the community setting, or a patient may have to travel a long distance to have a biopsy. I say everybody has a great phlebotomist. So I think the availability of the liquid biopsy and plasma-based testing is really going to open up serial monitoring and more testing in the community setting, because this can be performed with a simple blood draw rather than having to travel in many instances to have a targeted biopsy by a pulmonologist or a radiologist performed.
So a question about if there was a need to do a test and the lab did not have the capability to perform that test themselves in-house, what are some of the questions that they can ask or some of the data that they can look at to ensure that the lab they're looking to send their samples to is an accurate quality lab? Do you have any thoughts on that? Right.
That's a good question, is how do you vet a lab, so to speak, that you are sending out testing to? Many of the labs, the large commercial reference labs, are happy to share their QA and QC processes or tell you how they validated a test, which can be exhaustive. Many of them have published their data. I would always shy away from a lab that is hesitant to share what test they perform, what method they use, or tell you how they validated a test. I think you want to look for a lab that's not really hiding anything. A lab should be an open shop to tell you how they perform a testing and how they validate testing, because if you're comfortable with your methods, I don't think anyone is uncomfortable with telling people about those processes. And it can be quite challenging because there is a lot of direct marketing of testing to oncologists, and in many instances, many of these companies are avoiding the pathology loop altogether and directly marketing to the oncologist. So it can be very challenging for a provider to determine what is a good, accurate method to be used for their patients versus what is a slick marketing brochure that looks good but may not be the best type of testing for your patients. So certainly a great question.
Great, and I think we have time probably for one or two more questions, so if you'd like to submit questions, please use your Q&A button. There's one here for you. Do you have any thoughts on recommending aptamers as an alternative to antibodies?
That's really something that is far out of my area of specialty, so I'm not going to attempt to show my ignorance about aptamers and antibody testing by attempting to answer it, but I'm sure there's somebody out there much better qualified than I am. I am much more of a DNA-driven person than an antibody-driven question, so I'm sorry for not being able to answer that for you.
Okay, at this time we don't have any more questions. So I would once again like to thank Dr. Longshore for his wonderful presentation. And do you have any final comments before we conclude?
No, I just thanks everybody for your participation today, and I hope you have found the comments useful. Thank you again to LabRoots and to Roche Diagnostics for supporting this, and many thanks to Karen for moderating the session today.
Okay, a reminder for listeners out there, this is an educational webinar and thus offers free continuing education credits. So once we conclude the webinar, please click on the CE button located in the bottom left-hand corner of your webpage and follow the process to obtain your credits. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through October 7th of this year. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's event. Thank you so much for joining us. We hope to see you again soon, and that concludes our presentation for today.